Good evening to esteemed faculty members and dear delegates. It is my pleasure to welcome you all to the International Speaker Series Session 5 organized by AstraZeneca. Today we have the privilege of hosting a distinguished international speaker, Dr. Shaina Daud ma'am, who will share her expertise on the topic Look Beyond PIK3CA in HR plus HER2 breast cancers. I extend a warm welcome to Dr. Shaina ma'am. Her insights will enrich our understanding of this critical area of research. I heartily welcome to our esteemed faculty members also. I would like to I would also like to take this opportunity to thank all the delegates who have registered for this webinar. So with that, please drop your questions in the Q&A box, which you can see on the screen, and we'll address them at the end of the session. So, with that, I would like to formally welcome everyone and let us proceed with our first session. For that, I would like to invite Dr. Shaina ma'am, who is consultant in medical oncology and professor from Mediclinic City Hospital, Dubai, to begin her presentation on Look Beyond PIK3CA in HR plus HER2 breast cancers. Thank you, ma'am, and let us get started. You can share your screen.
Thank you so much, and thank you for the invitation. I've truly enjoyed the last 5 sessions. Let me just open my screen so that I can see it. All right. Oh, there it is. Okay. I hope you can see my slides. And now I'm trying to share it. Okay.
Yeah, ma'am, we can see. Yeah,
Thank you.
yeah.
In the last of the series of marathon webinars that we've been having, which I hope that you've been enjoying, and I've tried my best to make it really from the perspective of a community oncologist and how you're trying to think about things on the ground in the clinic in front of the patient and how to tease out that data. Today we're going to look at another very important component of patients with hormone receptor positive HER2 negative metastatic breast cancer and looking at other targets and actually looking specifically at those patients who've got a PIK3CA mutation. These are my disclosures, and if anybody would like to get in touch with me offline, I'd highly encourage you to scan the QR code. I've shown this slide a dozen times already, and I can't say it enough. The biggest development we've had in patients with hormone receptor positive HER2 negative metastatic breast cancer in the last 2 decades has been the introduction of a CDK4/6 inhibitor in that first line setting, which has improved significantly the progression-free survival as well as the overall survival of patients. But what are the key components that influences the journey of a patient with hormone receptor positive HER2 negative metastatic breast cancer? And I think it's important to understand this because that journey starts at the time that you give a CDK4/6 inhibitor and it evolves over time. And we need to understand that the first and most important component is to try and determine a patient's endocrine sensitivity. We know that if they have stage 4 de novo disease, they're inherently endocrine naive and will have endocrine sensitive disease. If they have recurrent breast cancer, it really depends on when they actually recur. If they have an early relapse, they're likely resistant. If they relapse a little bit later on, they have an acquired secondary resistance. And then if they start relapsing much later on, they're usually moderately sensitive. And if they relapse post completion of the endocrine therapy, these patients are endocrine sensitive. And it depends on which part of this journey someone actually develops recurrence that actually tells you how you need to treat them. Component number 2 is actually understanding the drivers of endocrine resistance. We know that the drivers can either be ER dependent or independent. If it's ER dependent, these are patients that are acquiring an ESR1 mutation that results in constitutive ER activity, upregulated coactivator binding, and stability against proteolytic degradation. But in those patients who've got ER independent resistance, they've got alterations in multiple pathways, including that PI3 kinase pathway and the MAP kinase pathway as well. Component number 3 is the recognition that when you're sitting with your patient in the clinic, there are so many different targets you need to be thinking about in a patient with hormone receptor positive HER2 negative metastatic breast cancer, and that is the ER, PR, and HER2. That can change over time. Never forget to biopsy your patient. The development of an ESR1 mutation, which makes these patients more sensitive to oral SERDs and SERMs. the defects in the DNA repair pathway, which makes them candidates for PARP inhibitors, alterations in the AKT pathway, which makes them candidates for AKT inhibitors and PI3 kinase inhibitors, and of course, those agnostic markers like HER2 mutations, NTRK, and RET fusions and alterations, as well as TMB. Now, I love this study. It was the Aurora Molecular Screening Initiative that actually looked at patients based on their endocrine sensitivity as well as molecular markers. And in a nutshell, what you see here on this slide is that it not only depends on the endocrine sensitivity, it also depends on the molecular markers. That means different types of mutations, where you can see that the prognostic outcome is very different. Your patient with endocrine sensitive disease will obviously do the best. Your patient with primary endocrine resistance will do the worst. And then depending on the type of molecular alteration, you're going to have differential prognostic outcomes, resulting in an impact on the progression-free survival. Irrespective, this is what we do in the clinic. You start your patient off on endocrine therapy plus a CDK4/6 inhibitor. They progress eventually, and then you look to see if they have a biomarker present and they're not in visceral crisis. You run through all those lines of combination endocrine therapy and then go on to systemic therapy. If the biomarker is not present, you run through all the lines of endocrine therapy and you add a CDK4/6 beyond progression or everolimus, and then you get on to systemic therapy. And then if your patient is in visceral crisis, you sometimes consider giving systemic therapy first before going on to combination endocrine therapy. And the real question is, how do you determine the optimal endocrine therapy options, because we have so many of them? So the way I thought we would work through this is actually look at a case study. This is a 45-year-old lady. She's married with 2 children. She's diagnosed with stage 4 de novo breast cancer. Sites of disease include lung, liver, and bones. She's got extensive disease. Biopsy reveals an ER positive, PR positive, HER2 positive, but FISH negative disease. And the question that you ask yourself is, what is the optimal first line of therapy? As I said, first line therapy would be CDK4/6 inhibitor plus endocrine therapy. We have data from Paloma 1 and 2, Monarch 3, and the Mona Lisa trials. It tells us in that first line setting, in that endocrine sensitive setting, there is an overall survival advantage with using a CDK4/6 inhibitor plus endocrine therapy, and that's exactly what we did. We treated her with a CDK4/6 inhibitor and aromatase inhibitor. She's premenopausal, so we gave her ovarian function suppression. Unfortunately, her disease-free survival, or it should be actually progression-free survival here, was 24 months. And the question was, what next should we be giving this particular lady? Well, you could potentially give her a CDK4/6 inhibitor beyond progression of disease. We certainly have the results of the post-Monarch trial. This was a phase 3 randomized clinical trial amongst patients who had progressed on first-line endocrine therapy and then randomized to get, that was endocrine therapy plus a CDK4/6 inhibitor, and then randomized to get either fulvestrant alone or fulvestrant plus a CDK4/6 inhibitor. And you can see that in the primary endpoint of progression-free survival, it did actually improve. You can see a hazard ratio of 0.73, but the biggest benefit was really in those patients perceived to be endocrine sensitive by having been on a CDK4/6 inhibitor prior to enrollment for more than 12 months. But post CDK4/6 inhibitor, there's several important issues to consider. Type of therapy may be dictated by endocrine sensitivity. Single agent endocrine therapy is associated with a modest benefit at best, and you can see that giving fulvestrant on its own results in a benefit of only 5.3 months. So again, it's a modest benefit at best. And it is important to look for targets and think about combination endocrine therapy in 2025. So one of the pathways that we haven't discussed to date is actually that alteration in the AKT PI3 kinase pathway, where we know that targeting this pathway is important. Patients with breast cancer who are progressing is often associated with pathway activation in the PI3 kinase AKT pathway. This is probably one of the most common alterations. We know that the activation of this pathway results in promotion of resistance to some of the therapies in breast cancer, including endocrine therapies, including chemotherapy. And we know that AKT is a key node within that PI3 kinase pathway. And disruption of the AKT can actually result in prohibiting the proliferation of cancer cells. We know that about 50% of patients with hormone receptor positive HER2 negative metastatic breast cancer will have some alteration in that AKT pathway, 40% of which, that means the largest proportion of them, will actually have an alteration in the PI3 kinase pathway. Now, we do know from studies such as the SAPPHIRE study that if you have a mutation in the PI3 kinase pathway, it is actually associated with a worse prognostic outcome than if you do not have a PI3 kinase mutation. Now, do these mutations actually change over time? Well, in terms of PI3 kinase, you can actually see that a number of different retrospective as well as prospective cohort studies and real-world data actually tells us that PI3 kinase mutations, they actually stay static over time. So even if you tested the primary tumor rather than the metastatic lesion, the probability that it's going to be positive is going to be very, very similar. Now, there's several targets that have been used to try and target the AKT pathway. You've got alpelisib, which is specifically a PI3 kinase inhibitor, everolimus, a very old drug that we used to use in the past, which is an mTOR inhibitor. And then, of course, you've got capivasertib and epatisertib, both of which block the AKT pathway. Now, one of the first trials to actually look at targeting PIK3CA mutations is the SOLAR-1 trial. The SOLAR-1 trial was a randomized phase 3 double-blind placebo-controlled clinical trial that took patients with hormone receptor-positive HER2 negative metastatic breast cancer who had progressed on prior aromatase inhibitor, and these patients were randomized to get either alpelisib plus fulvestrant or fulvestrant alone. And you had two cohorts. You had a cohort that had a PIK3CA mutation and a cohort that had no PIK3CA mutation. Now, the authors of this study did mention that only approximately 20 patients had actually received prior CDK4/6 inhibitors. So again, this was essentially a CDK4/6 inhibitor naive cohort of patients. Now, amongst the patients who did not have a PIK3CA mutation, there was no difference between the two arms of the study. But amongst patients who had a PIK3CA mutation, you can see that in terms of progression-free survival, it improved the progression-free survival from 5.7 months to 11 months, associated with a 33% reduction in the risk of progression of disease that was statistically significant. They then saw on further follow-up that there was an improvement in overall survival, especially in those patients who had lung and liver metastases, where there was an improvement, a clinically meaningful improvement in overall survival from 22 months to 37 months. Unfortunately, it was not statistically significant. So the questions that were asked post SOLAR-1, would it work post a CDK4/6 inhibitor? Now, this was a very important question to ask because all our patients now in that first line setting will get a CDK4/6 inhibitor. And could we potentially combine alpelisib with an aromatase inhibitor? And I think these two are very important questions. And this set the stage for the BYLieve study, which actually took patients who had all progressed on a CDK4/6 inhibitor. And this was a multi-cohort study. In cohort A, they had received prior CDK4/6 plus an aromatase inhibitor. Then they went on to get alpelisib plus fulvestrant. You can see the median progression-free survival was 7.3 months. Cohort B had prior CDK4/6 inhibitor plus fulvestrant, and they then went on to get alpelisib plus letrozole, and the median progression-free survival was 5.7 months, essentially telling us that alpelisib could be combined with either fulvestrant or with letrozole, and they both work post CDK4/6 inhibitor. But the next question came with SOLAR-1 because alpelisib specifically targets the PIK3CA mutation. The question was, could we use a drug that could potentially block multiple levels of the AKT pathway as a whole so that a broader cohort of patients could potentially benefit from combination endocrine therapy? And this set the stage for capivasertib, which essentially is an ATP, a competitive inhibitor of all three AKT isosomes, and co-targeting the ER and PI3 kinase, AKT and PTEN pathways through the combination of capivasertib plus endocrine therapy was thought to be a viable strategy in patients with hormone receptor positive disease. So this set the stage for the first phase 2 trial, which was the FACTION trial, that looked at the combination of capivasertib plus fulvestrant, and these patients were randomized to get capi fulvestrant versus fulvestrant alone. And you can see that in the overall cohort of patients, it improved the progression-free survival from 10.3 months to 4.8 months, and it improved the overall survival from 20 months to 26 months. And when you look specifically at those patients with an activation or an alteration in that AKT pathway, you can see an improvement in the progression-free survival from 9.5 months, from 5.2 months to 9.5 months. And you can see in those non-altered patients, there's also an improvement in the progression-free survival from 4.8 months to 10.3 months. So this set the stage for the phase 3 randomized clinical trial, the Capitola 291 trial. This was a phase 3 randomized double-blind placebo-controlled study that took patients who'd progressed on prior endocrine therapy. They were allowed to have one line of chemotherapy. About 50, they were allowed to have prior CDK4/6 inhibitors, and at least 50% of these patients had to have prior CDK4/6 inhibitors. These patients had to be randomized to either fulvestrant or fulvestrant plus capivasertib, and they had dual primary endpoints of progression-free survival in the overall cohort and in that AKT altered pathway cohort. And you can see it met its primary endpoint. In terms of progression-free survival in the overall cohort, it improved the progression-free survival from 3.6 months to 7.2 months, that allowed an absolute benefit of 3.6 months. And in the AKT altered population, it improved the progression-free survival from 3.1 months to 7.3 months, giving us an absolute gain of 4.2 months in terms of progression-free survival. Now, when you look specifically at those patients who had received prior CDK4/6 inhibitor, it worked, and it worked very well in terms of giving the combination of capivasertib plus fulvestrant, telling us they didn't matter whether you got prior CDK4/6 or not, giving the combination actually worked. When you looked specifically at those patients who've got alterations in the AKT pathway, it's important to identify. Remember, it's not only PI3 kinase mutation or PIK3CA mutation, it's also looking at those other alterations like AKT and PTEN. And what you essentially see is, although the majority of patients will have an alteration in the PIK3CA, you do have a good proportion that also have alterations in the AKT as well as PTEN, and a small subgroup that actually have that overlap in terms of co-mutations. So in a subgroup analysis, what you essentially see from the Capitola 291 trial, that if you have an alteration only in the PIK3CA, or an alteration in the AKT1, or an alteration in the PTEN pathway, you can see that giving combination endocrine therapy benefited patients with capivasertib plus fulvestrant versus fulvestrant alone. And if you look at that forest plot in the patients who have the altered population versus the overall population, every subgroup of patients is actually benefiting from the combination of capivasertib plus fulvestrant. But it's not only about alterations in the AKT pathway, because when you're looking at a patient in the clinic, you can't look at them in isolation. Remember, I've actually discussed this before in my prior presentations, that patients who have an ESR1 mutation, they are candidates for oral SERDs. We have data from the Emerald study, we have data from the AMBER-3, as well as SERENA-2, that tells us when you use an oral SERD, it trumps fulvestrant in that ESR1 mutation cohort. But unfortunately, you do see this really big drop in the Kaplan-Meier curves initially, telling us there's a group of patients that are just simply very, very resistant to endocrine therapy, and you need to do something else to prevent that drop in the Kaplan-Meier curves. And to do that, there's now combination of an oral SERD with a CDK4/6 inhibitor. Again, this comes from the AMBER-3 trial, where they combined imlunestrant plus plus abemaciclib, and you can see that it does partially overcome that drop that you see in the Kaplan-Meier curve, telling us that there is combination endocrine therapy that can be used in the ESR1 mutation. To make the story more complex, I've discussed this before, the SERENA-6 trial looked at actually looking at an acquired mutation with ESR1 over time, and before radiological progression, actually switching these patients who are on CDK4/6 plus AI to camizestrant, which is an oral SERD, plus CDK4/6. You can see a very nice separation in the Kaplan-Meier curves in terms of progression-free survival, with that drop practically not there, telling us the earlier you do the switch, the better it is. Now, going back to my patient, remember she had a progression-free survival, apologies for the error here, it's not supposed to be DFS, but PFS is 24 months. So how best to test for the targets and when? Because I need to know, am I going to target ESR1? Am I going to target an alteration in the AKT pathway, or is there another target that I'm going to use that may be good for this patient? So how best to test for targets, and when should you be testing? Well, when you're focusing on that alteration in the AKT pathway, it's important to understand that PIK3CA mutations are oncogenic driver mutations, and they're, like I mentioned before, they're found in similar frequencies in both primary as well as metastatic lesions, and 40% of both metastatic as well as early stage breast cancer patients do have a PIK3CA mutation, and it can be tested either pre or post progression of CDK4/6 because they tend to stay the same. If you have them at the beginning, you're going to have them at recurrence of disease. AKT and PTEN tend to be clonal or acquired. So I actually have a patient right now that I just tested with a liquid biopsy where she didn't have, and I've tested it multiple time points, where I've seen her acquire an ESR1 mutation, but she had no alteration in the AKT pathway initially, and I just got her results back. She now has an AKT alteration, telling us that yes, they can be clonal, but there can also be an acquired alteration in the AKT pathway. Now my patient is actually a candidate for capivasertib plus fulvestrant. You can see from the Capitello trial that the majority of patients actually had alterations in the PIK3CA mutation component, but you do have about 5% of patients who had an AKT alteration and about 6% of patients who had PTEN alterations. Now, the recommendations, and I know there'll be a big discussion on this, the recommendation is to use next generation sequencing to test patients for these biomarkers, be it ESR1, be it a PIK3CA mutation or an AKT alteration or PTEN alteration, because it is more efficient and less expensive than doing single gene testing. It is recommended to do NGS testing at metastatic diagnosis or on progression of disease. I have to say that all my patients, at the time that they're diagnosed with metastatic disease, I tend to test them. In actuality, if cost is an issue, you can do it at progression of disease, and you can use either for PIK3CA mutations or alterations in the AKT pathway, you can use either the primary or the metastatic lesion. I usually prefer the metastatic lesion because you want to look at those other acquired mutations as well. Now, is there a role for liquid biopsy, or is it only about tissue? Well, of course, there's a role for liquid biopsy, and I've shown this data to you before. The plasma match study really set the platform for us to use liquid biopsies in the clinic. These were patients with recurrent metastatic breast cancer. They had liquid biopsies that were done to detect ESR1 mutations, HER2 mutations, AKT alterations, as well as PTEN alterations, and then they were appropriately targeted. And you can see, based on these liquid biopsies, some very nice response rates and median progression-free survivals when you appropriately targeted those biomarkers that you saw acquired with a liquid biopsy. What are the advantages of using a liquid biopsy method as compared to using a tissue? Well, at least for ESR1 mutation, it tends to have a higher sensitivity, but other advantages it is that it allows for capture of heterogeneity and allows for testing of multiple time points, so it's sometimes very difficult to actually do tissue biopsies repeatedly. And what they also showed from the plasma match study, that when they compared the data that they got with the liquid biopsy to that acquired from tissue NGS, the highest concordance was really with PIK3CA mutations and AKT alterations, and the least sensitivity of the tissue versus the liquid actually came for ESR1, telling us that liquid may be better for ESR1 compared to tissue testing. Now, is there a role for doing immunohistochemistry testing for PTEN? And I was actually very interested in this because sometimes you can't do NGS for everyone and you want to have a quick information that gives you within 48 hours the results. And so the authors of the Capitello 291 trial actually conducted an exploratory analysis looking at PTEN deficiency detected by IHC. And interestingly enough, they found a good concordance between PTEN status by IHC and PTEN alteration by NGS. But what was really interesting was this overlap. You can actually see that there's a good overlap by PTEN alteration by NGS and IHC, but there's a good percentage of patients that are detected to have PTEN alteration by IHC that's actually not detected by NGS. And when you looked at the progression-free survival amongst patients where they had that IHC to detect PTEN alteration, you can see that giving capivasertib plus fulvestrant worked versus giving fulvestrant. So again, capi fulvestrant better than fulvestrant when you tested for PTEN, looking at that IHC methodology. Now, my particular patient, we did a liquid biopsy because she categorically refused to do a biopsy of the tissue, and she's got a co-mutation with a PIK3CA mutation as well as an ESR1 mutation. So the question is, what to target first? Well, remember, she has a DFS of more than of 24 months. And when you go back to the Emerald trial that looked at elacestrant, you can see that amongst patients who had had prior CDK4/6 inhibitor for more than 12 months, if you had a co-mutation with ESR1 and a PIK3CA, elacestrant worked, and it worked pretty decently. Now, what if this patient had recurrent disease and had relapsed while on adjuvant endocrine therapy? Because remember, I said she had stage 4 de novo disease, but let's switch it around a little bit and assume that she had recurrent disease. Do we need to target the PIK3CA pathway earlier? And this is what the INAVO 0120 trial actually looked at. This was a phase 3, very innovative study that took patients who had a PIK3CA mutated metastatic breast cancer, naive in therapy in the metastatic setting. Look at the inclusion criteria. Patients had to have progression during or within 12 months of adjuvant endocrine therapy. And when you look at the details of the trial, it also included patients who had never received an aromatase inhibitor, who'd only gotten tamoxifen and had relapsed on tamoxifen. These patients were randomized to get either triplet therapy with a PIK3CA inhibitor inavolisib plus CDK4/6 inhibitor palbociclib plus fulvestrant versus getting palbociclib plus fulvestrant. Primary endpoint was progression-free survival. You can see that 48% of patients had received adjuvant tamoxifen alone, 48% were premenopausal, 34% had primary endocrine resistance, and 66% had secondary endocrine resistance. So a really, really bad group of patients in terms of prognosis, and 1.9% had adjuvant CDK4/6 inhibitor. At a median follow-up of 21.3 months, you can see a clear-cut improvement in progression-free survival, 7.7-month improvement in PFS associated with a 57% reduction in the risk of progression of disease with a very early separation in the Kaplan-Meier curves. And in terms of overall survival, initially there was a trend towards overall survival improvement. And this year at ASCO, we saw a significant improvement in terms of overall survival, really set the stage as this being the standard of care. So the questions I asked post INAVO 0120, no doubt it is practice changing. You cannot beat an overall survival advantage. And it tells you need to test for PIK3CA mutation as early as possible in that pathway. But many questions remain. Does duration of disease-free survival make a difference? That means, is a patient with a DFS of 10 years the same as a patient with a DFS of 1 year? Is palbociclib the best partner? Is fulvestrant the best partner, especially in patients who've never seen an aromatase inhibitor? What do you do in the presence of a co-mutation with an ESR1 mutation? Where would Serena-6 fit in all that? Is sequencing therapy going to provide the same advantage? And what will happen to those patients who actually have used an adjuvant CDK4/6? And that sets the stage for the question, What if this patient had received adjuvant CDK4/6 inhibitor? It just makes the story more complicated. And this is just my thought experiment, and this is what we're all going to see because the majority of our patients are now going to receive adjuvant CDK4/6 inhibitor with abemaciclib and ribociclib. And the way I think about it, you have to see when the patient relapses. If the patient relapses on the CDK4/6 inhibitor, I classify them as having primary resistance to CDK4/6. You need to biopsy these patients, confirm biology, and target those biomarkers. If they relapse post CDK4/6, they've got secondary resistance. And if they've progressed way beyond that, they've got still sensitive disease to CDK4/6, where you could potentially challenge these patients to getting a CDK4/6 inhibitor. Now, coming back to my patient, she also has HER2 low disease. Should we be targeting this? Why do I ask this question? Because we have the results of the Destiny Breast 06 trial that tells us in your chemo-naive patient, HER2 low, and these patients were randomized to get TDXD or physician choice of chemotherapy with a primary endpoint of progression-free survival, and I show you the results in a minute. These patients who were enrolled in this study either had to have more than 2 lines of endocrine therapy or 1 line of endocrine therapy plus a progression-free survival of less than 6 months on first-line CDK4/6 or recurrence less than 24 months of starting endocrine therapy. And you can see in these patients, TDXD trumped physician choice of chemotherapy, especially in those patients who'd received prior CDK4/6 for less than 6 months, so that really truly hard to treat cohort of patients. So my personal opinion, if your patient has progressed on a CDK4/6 and they've got HER2 low disease and their PFS is less than 6 months with no biomarker, give TDXD. If the PFS is less than 6 months and they've got an alteration in that AKT pathway with a moderate to low burden of disease, I would give combination endocrine therapy with capi or alpelisib and then go on to TDXD. But if they've got a high burden of disease that's rapidly progressing, I would probably start with TDXD. But if they've got a PFS of more than 6 months, just like my patient, remember 24 months, and they have a biomarker present or they don't have a biomarker present, use your endocrine therapy options first before going on to TDXD. So in this case, the decision was to target target the PI3 kinase pathway with capivasertib and fulvestrant. This was actually one of my first patients that I put on capi, and you have to understand that not all PIK3CA targeted agents actually have the same toxicity profile. So we've got Inavo with enovelisib, we've got Solar with alpelisib, and you've got Capitello with capivasertib. And you can see there are differences. In terms of hyperglycemia, Capitello with capivasertib is the least. In terms of diarrhea, you can see that capivasertib has a slightly higher incidence of diarrhea. In terms of rash, again, alpelisib tends to have the highest incidence of having rash. In terms of stomatitis, actually is pretty low with capivasertib. So again, my patients who are taking capivasertib, actually, I don't usually talk about too much with stomatitis. They tend to do very well, but I do educate them on all possible side effects. So this is what I will do on Monday in the clinic for my patients with hormone receptor positive, HER2 negative breast cancer. I think it is important to recognize that not all patients with hormone receptor positive, HER2 negative MBC are the same. They are also not the same at every time point in their journey. Our ability to define, recognize, and appropriately use biological profiles at various time points combined with the clinical profile of patients will be paramount in improving outcomes. All patients will receive a CDK4/6 inhibitor either in the endocrine sensitive or resistant setting, and post CDK4/6 therapy direction will be guided by biomarker identification. In the absence of biomarker identification, it is reasonable to use a CDK4/6 beyond progression of disease for a select group of patients. But we now also know in that biomarker identified population, we have two inhibitors, one an AKT inhibitor, the second a PIK3CA inhibitor, that is capivasertib and alpelisib, that can be used in clinical practice with capi having a broader indication in terms of alterations, but it does have different toxicity profiles. We also have oral SERDs for our patients with ESR1 mutation. In a select group of patients, I will consider earlier use of TDXD per the Destiny Breast 06 criteria. And finally, I will always consider the patient profile, toxicity profile, and patient choice when considering any therapeutic strategy. So thank you very much.
Thank you so much, Dr. Shaina ma'am, for delivering a truly engaging and informative session. We greatly appreciated your valuable insights and expertise. So, ma'am, we have few questions for you. Should I read them for you?
Sure.
So, ma'am, first question is, how does gedatolisib, a multi-target PI3K or AKT or mTOR inhibitor, compare to other PI3K inhibitors in terms of efficacy and safety in HR plus HER2 breast cancer?
I think we've got just very preliminary data on this particular agent, and we're looking to see some of those bigger studies using it. But in general, I think in terms of toxicity profile, I find it very similar. I think all the AKT inhibitors and PI3s, PI3 kinase inhibitors have very similar toxicity profiles. Just the incidence of those different side effects are different. In terms of efficacy, I would wait and watch and see that space for now.
Okay. Thank you so much, ma'am. Ma'am, next question is, how might the addition of capivasertib to fulvestrant impact treatment decisions for patient with HR plus HER2 advanced breast cancer?
I think the fact that we now has this is my answer to the question. You cannot use single agent endocrine therapy for any patient in the second line setting and beyond in 2025 because we know that it's not enough. If your patient has any alteration in the AKT pathway, add capivasertib. If they've got specifically a PIK3CA mutation, you can either add capi or alpelisib to get that enhanced efficacy. So I think it's important to target it. I think the fact that capivasertib is now introduced, it enhances the efficacy of fulvestrant in these patients with an altered pathway in the AKT pathway.
Okay. Okay, ma'am. Next question is, what is the median PFS for patient who received capivasertib plus fulvestrant versus placebo plus fulvestrant in the overall population and in those with AKT pathway altered tumors?
So I think that was my first slide, right? That the progression-free survival was significantly improved both in those patients who had AKT alteration when you added CAPI and in the overall cohort. I think the more important question that you need to be asking is why did the FDA only approve it in the AKT altered pathway patients when it is clearly working even in those non-altered pathways? So that was one of my first slides where I showed it that it was improving and it was improving very well in terms of the PFS.
Okay. And second last question. So what are the potential implications of the Capitello 291 trial results for the treatment of HR plus HER2 advanced breast cancer, particularly in patients who have progressed on or after CDK4/6 inhibitors?
It's practice changing. That's my simple answer for it. A patient who progresses on CDK4/6 inhibitor and has an alteration in the AKT pathway needs combination endocrine therapy, either with capivasertib for all the alterations or alpelisib specifically with for a PIK3CA mutation.
Okay. Okay, thank you, ma'am. And last question. How does the addition of abemacicillin to endocrine therapy impact the timing and the site of recurrences?
So basically, this is a very broad and long-winded question because abemaciclib is a CDK4/6 inhibitor. And when you use it in the first line setting, it's different from using it in the second line setting. So when you're using it in the endocrine sensitive setting, it improves progression-free survival and it reduces the risk of progression of disease at multiple sites. It works the best in those patients who've got liver metastases, so visceral disease. It also works in endocrine resistant patients where it primarily works in those patients with primary endocrine resistance. So really those tough to treat patients where it does the same thing. Primarily in those patients with visceral metastases, it works and it works very well.
Okay. Yes, ma'am. So that's it. Ma'am, thank you so much. We greatly appreciated your expertise. So, next, moving forward, we would now like to transition to our next session, which features a panel discussion on NGS testing in breast cancer. The devil is in the details, which will be moderated by Dr. Ramya. She's a senior consultant in medical oncology from Apollo Proton Cancer Center. Welcome, ma'am. And ma'am, I would like to invite your panelist. So first, we have Dr. Samson. He's principal research scientist from Rajiv Gandhi Cancer Institute and Research Center. Next, we have Dr. Sarjana Dutt, who is lab director from National Reference Lab, head molecular biology of cytogenetics, pathkind diagnostic from Gurugram. Dr. Defin, uh, who is senior consultant in pathology from Basavata Rakam Indo-American Cancer Hospital and Research Institute. Dr. Anil, he's senior consultant from Coimbatore Molecular Diagnostic Laboratory. Dr. Kumanan, he's consultant in medical oncology from KIMS Health. And Dr. Vishwajit, he's consultant in medical oncology from HCG Cancer Center, Bangalore. Thank you, ma'am, and over to you.
Thank you so much, Priyanshi. And it is all.
Yeah, Dr. Ramya, sorry for the interruption. I think Dr. Sarjana won't be able to join because there is some, and also Dr. Vinit because there is some family emergency at their end. So,
sure.
Over to you, ma'am. Yeah.
Thank you so much. And it is always a pleasure listening to Shahina ma'am. And I think the ma'am has covered more. We're going to be having the panel discussion. So let me share my slides, and the slides are visible?
Yes, ma'am, it is visible.
Yeah. So we'll be discussing about NGS testing in breast cancer, and we have a panel of both medical oncologists as well as molecular oncologists and pathologists here. So we'll be dissecting into the methodology of testing and how significant and important it is to test it in clinical practice. Now, moving on to the I think ma'am has elaborately explained and given a very, very, very explanatory session on what is the standard of care in treating a hormone positive HER2 negative breast cancer. Earlier, we were just stuck with few options, like we had AIs, and then we had fulvestrant, and then we had everolimus. Then we were on short of options as far as the hormonal segment is concerned. But I think now with the understanding of the tumor biology and understanding of the targets that are possible, the armamentarium of second line option has extensively improved, be it the AKT pathway, be it PI3K, or be it the ESR1 mutation, or even the germline BRCA mutation. All of that has come into the second line therapy of advanced breast cancer. But how do we choose it? How do we test for it? And how do we sequence it? I think these are the questions that we still don't have complete answers to. Now, I have an extremely well-informed panel here. So I would first like to ask, is Dr. Kumran is available?
Yes, ma'am, I'm available.
Yes. So I think we have heard what Dr. Shahina ma'am mentioned, and a lot of second line options are coming into practice right now. So in your practice or in your experience, what do you consider will actually enter the second line therapy phase in the near future? We have four options, but if you have anything else in mind also, please enumerate.
I mean, after the first line failure, if there is a predictive biomarker like PIK3CA mutation, initially I used to give alpelisib and fulvestrant, but now having the capivasertib, which has a better tolerance and good coverage of not only PIK3CA but also PTEN and AKT pathway, capivasertib available, that will be my go-to option in the second line. And of course, alpelisib and fulvestrant, the conventional option is also a good one.
Yes, agreed. Shahid?
If other predictive biomarkers like ESR1 is present, then we have to act accordingly, like elastocin can come into play.
Agreed. Dr. Shahina ma'am, are you available, ma'am? Can I pick your brains for a minute? Okay, I'll move on. So I think Dr. Kumran was very clear. We have multiple second line options that have come in, and I think with the availability of capivasertib, and the toxicity profile is very much different from alpelisib. So many of our colleagues are shifting on to second line capivasertib barring the availability issues. But because we don't see the hyperglycemia as much as seen in alcoholism, it's more of diarrheas and rashes, which is very much manageable. And so most of the second line therapy options have shifted towards capivasertib. That's well said, Dr. Kumar. Now, Dr. Vishwajit, a question to you. We have all done this in clinical practice. We have re-challenged CDK4/6 inhibitors, and instead of when we are not able to do a targetable mutation testing, we have always shifted to re-challenging CDK4/6 inhibitors. What is your take on that? Dr. Vish-
Yeah, I think re-challenging of CDK4/6 inhibitors after a failure of CDK4/6 inhibitors has not given really a big PFS benefit. In the best of my knowledge is about 3 to 4 months. Correct me if I'm wrong.
No, you're absolutely correct. Re-challenging CDK4/6 inhibitors, I think multiple trials were looked at. We had Maintain, we had Palmyra, we had PACE. They all had very different outcomes. One of it was positive. The abemaciclib plus fulvestrant trial was positive, but rest others did not show a benefit. So, but then I think we still do it a little bit in the clinical practice when we are not able to shift to any of the other options. Merely a financial decision is what I would think. And when we look at the prevalence of PI3K, AKT, PTEN alterations, close to 40 to 50% of our patients do have these changes. So that's a significant number. And if we have to divide them by all specific mutations, PIK3CA is going to be around 40%, AKT1 is around 5%, and PTEN, I think you have a differential prevalence based on the methodology of testing, which I think I'm definitely going to ask our panel here to understand more about that. It's 5% when you do it by NGS, and you have 40% prevalence when it's by IHC. And I think in the Capital 291, NGS was the predominant way of testing. They did not look at IHC before the trial was initiated. And the approval is also based on any marker AKT, PKPI3K, AKT pathway altered tumors. Just like as ma'am mentioned, we don't know why the approval was restricted to that group, though the benefit was seen in the entire study. But I think the magnitude of benefit was much, much bigger and deeper in the PIK3CA altered population. Now we have multiple ways to test in the clinic. So moving on to my panelists, Dr. Sampson, considering that you need both hotspots and you also need PTEN full gene spanning testings to be done, which one would you prefer to suggest to us? Say, I'm calling you to ask which one do you want me to do. So what do you think are the pros and cons of each methodology?
Always it will be best to do an NGS for a panel which is like kind of hotspot, not an hotspot, the kind of panel which looks at the entire gene. So always NGS is preferred to do this kind of testing. Maybe a clinical exome can also give an information about that, but I would prefer a panel of genes which looks at the entire region of a gene, including the introns and exons. So that can give you more information about this.
Agreed. I think practically also it will be easier thing to do an NGS.
Nowadays, the technology is so streamlined, so it will not be that difficult to do an NGS, and also the data interpretation, everything is become so much, what to say, the softwares and other things available, so that we have all information in case of any annotations has to be done, how to interpret a variant, what is the significance of the variants. So most of the things we all know, and nowadays it is a routine practice, and it's not that difficult task nowadays to understand NGS code and design a panel which looks for a specific disease.
Well said, Dr. Sampson. I totally agree. I think our reflex testing in our clinics also are predominantly an NGS for the same reasons. Dr. Daphne, do you think there are any standardized tests that are available for detecting these mutations in India? Anything specifically about the standardization that we as clinicians should be aware of?
To complement the answer what Dr. Sampson just told, of course, NGS is the best methodology. In addition, if IHC is used, it will detect the protein expression, the functional loss, and both could be ideally complementary in a given setting. Because even Capital O 291 showed discordance between IHC and NGS, and even the patients who were NGS wild type had IHC deficient tumors also still responded. So maybe IHC could detect those things which NGS may miss, like if NGS detects mutation, deletions, copy number loss, but may miss post-transcriptional or epigenetic loss. So probably both would be complementary. And with regard to standardizing,
Hello. Hello, am I audible?
Yes, ma'am, you are audible.
I think we lost Dr. Daphne.
sorry,
Yeah.
sorry, I by mistake it was on mute. So with regard to PET and IHC, I was just mentioning this. There is challenge in standardizing because there is variation in antibody clones, the protocols, and the scoring system.
Okay.
And also there
And
is we need training in interpretation so that there is
agreed.
yeah,
I think
and
we
the
are going to
cutoff
have a
points,
discussion on PETN as such. As you said, Dr. Daphne, I do agree. I think the IHC for PETN is evolving. We do have some analysis from Capitalo, which we'll be talking about. But we do agree that NGS is something that we automatically reflexly ask for. Do we add an IHC along with that? I think with better.
Can I ask Dr. Can I come in, Dr. Ramya?
Yes, please, Dr. Samson.
Yeah, I do agree with Dr. Daphne about the IHC, but nowadays there is a technology which is coming up with spatial transcriptomics. Maybe just
Okay. Hello?
after a period, maybe a 5 years after some the routine clinical practice. So that the kind of technology which is emerging, it will address and it will add on more into the kind of the thing we need, decisions we need to take in the clinic.
I think
so that's what I wanted to mention.
That's a good point, sir. I think we're all moving towards transcriptomics and proteomics in the near future. And now I think moving on to my colleagues here, Dr. Kumanan, how readily do you think that we are going to start looking beyond PIK3CA in India? Are we there yet? Are we not there yet?
I think with available data, I think it's time that we have to move on to the next targeted therapy available, probably capivasertib. As I said earlier, the better tolerance is the key here, because most of the patients whom I've started on alpelisib have a very high hyperglycemic index, and discontinuation rates were very high. So, and having a good coverage beyond PIK3CA and the downstream signaling pathway inhibitors, I think it's time we move on to capivasertib. Even I'm thinking about starting capivasertib. I have a patient of PIK3CA mutation and now progressing, and I'm going to counsel her next week. So I'm thinking of doing capivasertib on her. It's time to move on.
That's well said. Dr. Vishwajit, your thoughts on that. Between alpelisib versus capivasertib, what would be your choice? If you have an AKT altered tumor, alpelisib is something that we are all used to. We have been using it for quite some time. So what are your thoughts on that?
Question is capivasertib versus alpelisib, is it?
Yes.
Yeah, since the adverse event profile is more favorable with the capivasertib, I think I'll go with that.
So I think we all agree we are going beyond PIK3CA now in the clinics also. That's a nice thing to know. So I think we have discussed this. Dr. Daphne had nicely mentioned about the concordance between PETN alteration status by IHC and NGS. There is concordance, there is discordance also. So this was an exploratory analysis that was done, which showed the PETN IHC deficiency by PETN deficiency by IHC. And all of these tumors actually, which were deficient by IHC, seem to respond to the combination of capivasertib and our fulvestrant. So, Dr. Anil, sir, if I can pick your brains. The trial tested PETN by NGS and the exploratory analysis of IHC. We know that exploratory analysis is something we take with a pinch of salt. How would you prescribe PET? Like we have already had a discussion from Dr. Daphne that she would suggest to do both. Your takes on that, sir. Dr. Anil? Mr. Himanshu, Dr. Anil available?
No, I don't think so. I think Dr. Samson also has some network issues, I guess.
Okay. So I think, so I have Dr. Samson, Dr. Daphne, Dr. Kumaran, and Dr. Vishwajit,
Yes.
correct?
Yeah, Dr. Samson, actually, we are not able to hear you.
No, I'm here. I'm here.
Yeah.
So I think, Dr. Samson said we can go back to the discussion of PTEN, but I think you've already answered it with transcriptomics and proteomics. And Dr. Daphne did mention that the PTEN IHC is not standardized in India. I also tried calling my molecular team to ask whether they can do a PTEN by IHC, and that's the same answer that I'm getting. Why is it that so? And do you think that in near future we'll be having a PTEN by IHC?
Dr. Ramya, your audio is also breaking now.
Oh, okay. Is it audible now?
No, ma'am. Actually, I can hear you.
Okay.
Yeah.
I think others are not able to hear. You're able to hear.
No, you're audible, Dr. Ramya. Everything is clear and good.
Clear. So I think Dr. Samson is network is okay.
Actually, the issue with the P10 IHC is the antibody, the clone. So that is the reason why we are not able to pick the thing by IHC. Maybe I think they are working on it. A lot of R&Ds have been done to pick up the right clones. Maybe in a year we'll be able to pick it up. So we were able to do for many other proteins, but now I think we will be able to do it in the coming years. It's basically the clones which is getting we are not able to detect. That's the problem. With the isoforms and other things.
Agree. So until the transcriptomics comes, if the IHC becomes available for PTEN, it will be probably do NGS and IHC together to make sure whether the protein is expressed or not. Am I right?
Both, yeah.
Both would be better. So now this capital, I think it's been discussed extensively. Now, I would like to ask both my colleagues here, Dr. Vishwajit. Considering that we have some actionable mutations that are acquired over time, when do you do NGS in your clinic? At diagnosis or at progression, or do you have any other timelines in mind?
At first line progression.
At first line progression. Dr. Kumran?
Same, ma'am. At first line progression, I would, because upfront, if you are going to do, there is no treatment implication. Unless if the patient has taken an adjuvant endocrine therapy and later developing a metastatic disease, that would be one place where I would like to do it upfront. Otherwise, it's first line progression.
Agreed. So I think you're talking about the INAVO trial. Like you have a patient who's on adjuvant endocrine and then you progress into metastatic disease, we would like to do the triplet. That is one place where we would want to do it at first line metastatic setting. Otherwise, it's as Dr. Vishwajit and you rightly mentioned, it's going to be at first progression. And about this co-occurrence of genomic alteration, Dr. Samson and Dr. Daphne, how often do you see these in your reports? We do see it quite often, but how often do you see in your reports? And if so, what is the most common co-occurring alteration that you see?
In our lab, we used to see PIK3 and AKT.
Yeah, PIK3, AKT. And Dr. Daphne?
I don't have any personal data or experience on this. I'm yet to look at the numbers.
Thank you, ma'am. Dr. Samson, how frequent have you seen these alterations?
We haven't done much, but to my knowledge, I think we have close to 20 patients last year.
Agreed. Okay, I totally agree, because the more we start doing NGS in breast, we are seeing all these co-occurring alterations. As clinicians, we are lost as to which one to target. And I think the data is yet to evolve in that aspect. So now moving back to Dr. Kumaran and Dr. Vishwajit, let's say we have a patient who has both ESR1 and you have a PI3K AKT alteration. How would you sequence, Dr. Kumaran?
This is like in upfront or progression, no?
Say the patient
I think
is not
progression.
Yeah, ESR1 is there, so we'll take it as a progression.
Okay, ESR1 is there. I'll go for elacestrant with a single agent elacestrant pump. Later, I can sequence it with fulvestrant and a CDK4 inhibitor or a PIK3CA.
Unfortunately, we don't have any combination trials with elacestrant. So I think the other combination trials, once we have results, we might be able to use it. Dr. Vishwajit?
Yeah, I would also go with elisestant alone.
The problem is we don't yet have clear data on how to sequence these therapies. Though PIK3CA is a truncal and clonal alteration which is going to be present right from your diagnosis, ESR1 is acquired along the way on hormonal therapy. But which do I target first? Do I target PIK3? Do I target ESR1? And will the sequencing bring about a change in overall survival? I think all these are questions that are yet to be addressed. And I think the entire scope of metastatic breast cancer is constantly changing and evolving with the evolution of all the targets. So now back to my molecular team, Dr. Daphne. The trial-wise, we saw about 10% patients who had pre-analytical failure. And how frequently do you face this issue in your labs?
Yeah, around the same, or sometimes we can reduce it also, because if you're a lab who is having the pre-analytics well in place, this failure rate can definitely be reduced. So we need to ensure as pathologists the cold ischemia time, which should not be more than 1 hour. If we have decalcified biopsies, we should avoid over decalcification. 10% neutral buffered formalin for fixation, and fixation timing, which should not be, less than, it should be not less than 6 hours and not beyond 36 hours or 48 hours. Even the specimen, the thickness when we cut in the microtome should be, around 4 to 5 mm, and good paraffin quality. All these really affect and give you good results. So it need not necessarily be a failure every time. If you follow your pre-analytics well, I'm sure Samson also would agree with me that we do get good results.
Nowadays, the pre-analytical failures are not that great if you follow good laboratory practice, especially in the DNA, the tissue preparation, or the DNA extraction. The kits are there, so which can give you a good amount of DNA if even the blocks are pretty old. So as Dr. Daphne said, the major concern would be how the biopsies are getting prepared. So what is the kind of formalin we use and how long it's been stored. So that basically gives you information how good your DNA extraction is going to be and how critical your data is going to come up. So those are the areas we need to get streamlined. But mostly nowadays, the pre-analytical failure, especially with respect to DNA extraction, it's not that very high.
And to
That's
add
good to
on,
know.
if a pathologist is involved, what we can do is the tumor content, the tumor area can be micro dissected so that, the yield is good and failure rates are reduced.
That's really good to learn from you, ma'am. I think we have already answered this question, and with that, I come to the end of my slide. Thank you to all my panelists, and thanks for the active participation. I hand it over back to the organizing team. Thank you.
Priyanshi, please take over.
Yes, sir. So in conclusion, I would like to extend our sincere gratitude to all the esteemed faculty members, delegates, and our distinguished international speaker, Dr. Shaina Daud ma'am, for their valuable contributions to today's webinar. We appreciate the time and expertise shared by our speaker, and we are grateful for the active participation and engagement for all the delegates. Your presence and contributions have enriched the discussion and made this webinar a success. Thank you for your participation, and we look forward to future collaborations and knowledge sharing opportunities. Thank you and good night to all.
Thank you.
Yes, ma'am.